Welcome to the Saving Lives podcast. I'm Eddie Joe. Today we're diving into something that we all face in the ICU, cardiogenic shock from acute decompensated heart failure. Before we get started, don't forget to check out the vasopressor and inotrope handbook. Links are in the show notes below for both Amazon and my Shopify store. We all know that timing matters. Door to balloon in STEMI, antibiotics in sepsis, thrombolytics in stroke. But here's the question. Does timing matter for inotropes in heart failure-related cardiogenic shock? A new study out of the University of Pennsylvania says yes, and maybe by a lot. But let's break it down. Cardiogenic shock used to mean acute myocardial infarction. That's where all the data came from. But over the last decade, the landscape has flipped. Now, nearly 40% of cardiogenic shock cases are from acute decompensated heart failure, not from an MI. And the scary part, mortality hasn't budged. It's still 30 to 50%. Despite all the devices, protocols, and fancy monitors, we seem to be stuck. So when I saw this study titled Timing of Inotropic Support and Mortality in Acute Decompensated Heart Failure Associated Cardiogenic Shock, wow, what a mouthful. But my thought was, hey, maybe it's not what we're giving, perhaps it's when. This was a retrospective look at 623 cardiogenic shock patients across 5 EDs at Penn between 2021 and 2023. Only 138 of these met the strict SCAI Stage C criteria, meaning true hypoperfused cardiogenic shock with low cardiac output. They split patients into early inotrope, meaning within 8 hours of shock recognition, and delayed, 8 hours or later. Their main outcome was 28-day mortality, which is pretty straightforward. But here's where it gets interesting. Mortality in the early group was 17%. In the delayed group, however, it was 32%. That's almost double the mortality if you waited more than 8 hours. But really, let's not get ahead of ourselves. This was observational data. This was not a randomized control trial, so we can't make a lot out of these data. But the pattern is consistent. The longer the delay to inotropes, the higher the odds of death. At 4 hours, the odds ratio for death was 3.19. Hey, that's 319. That's my birthday, March 19th. At 8 hours, it's still 2.4. Early inotrope patients actually look sicker on arrival, often more cool, had a higher lactate, and yet they survived more often. This tells me that this isn't just selection bias towards the well-appearing. It might be that the sickest patients who get treated aggressively and early actually do better. The biggest reason is that hypotension distracts us. Patients with delayed inotrope therapy were more likely to receive norepinephrine first, which fixes the numbers we can see, i.e. the blood pressure, but not the problem we can't, the low cardiac output. Even though data suggests that norepinephrine is a first-line therapy in cardiogenic shock of any modality, we should be prepared to start inotropes once we identify that it is cardiogenic shock. Our friends in the emergency department have some difficulty here because they rarely have hemodynamic data, like the ability to do echoes, float a PA catheter. I'm trying to train people to check mixed venous blood gases, so the default is fix the pressure first, but the macrocirculation doesn't always equal perfusion. We've learned that in sepsis. Now it's time to apply it to cardiogenic shock because by the time the hypotension shows up, you're often hours behind. So what do we do with these data? First, we should recognize that patients with acute decompensated heart failure should be hopefully recognized early, but also be aware that not all shock is hypotensive. About a third of these patients were normotensive with low cardiac output and hypoperfusion. Second, when you meet a patient who is in SCAI Stage C with hypoperfusion and low output, we should start inotropes within 8 hours, ideally much sooner. Third, we should try to assess hemodynamics quickly, either obtaining an echo, a pulmonary artery catheter, heck, even a lactate trend or capillary refill time will be helpful. Finally, we should build systems that support early recognition. Have a shock protocol, rapid echo assessments, and critical care consultation early from the ED. This isn't about giving everyone dobutamine. It's about giving the right patient the right medication at the right time. Here's the bottom line. Inotropic support within 8 hours of shock onset in heart failure-related cardiogenic shock was linked to half the mortality compared to waiting longer. We could debate the medication, dobutamine versus milrinone, which there's a whole chapter dedicated to it in the vasopressor and inotrope handbook, but timing might matter just as much. If sepsis taught us that early antibiotics saves lives, cardiogenic shock might teach us that early inotropes do too. Thank you for listening to this episode of the Saving Lives podcast. I'm Eddie Joe. Hope you enjoyed it. Have a great day. Bye.